Good afternoon, everyone, respected dignitaries on the dais. My topic for today's presentation is effect of pupillary dilatation on biometric measurement using manual and optical biometry methods. No financial interest. Ocular biometry is the measurement of the anatomical dimensions of the eye, which include corneal curvature, axial length, white-to-white thickness, anterior chamber depth, lens thickness. In this presentation, we have taken K1, K2 keratometry and axial length as the parameters under study. The axial length is defined as the distance from the anterior surface of the cornea to the retinal pigment epithelium and can be measured using ultrasound biometry or optical biometry. Ultrasound biometry can be further divided into contact or immersion type. Accurately measuring the axial length is very crucial because 1 mm error can change the IOL power by nearly 2.5 times. Keratometry is the measurement of the power of the cornea, which is based on the corneal curvature and is expressed in diopters, can be measured via manual or automated methods. The purpose of our study is we want to understand the role of pupillary dilatation and if it will alter the K1, K2 and axial length by using these instruments, because it plays a role in predicting the accurate IOL power and post-operative refractive status of the eye. Here is one study which has been performed previously, effect of pupil dilatation on biometric parameters using Lenstar 900, and they have found that the first keratometry value did differ before and after dilatation. Another study was conducted previously, the effect of pupil dilatation on biometric measurements and IOL power calculation in school children, and they have found multiple parameters to differ before and after dilatation, such as axial length, anterior chamber depth, and they have also mentioned that IOL power changes exceed 0.5 diopters before and after dilatation. Material and methods, we have taken patients visiting MNJ Eye Institute with complaint of diminution of vision or routine eye checkup. The inclusion criteria were patients in the age group of 14 to 70 years of age visiting the hospital. The exclusion criteria was patients with any known case of glaucoma, previous eye surgery, any corneal pathology, or a known case of drug allergy to tropicamide phenylephrine eye drops. It was a cross-sectional interventional study with 150 subjects, that is 300 eyes, and the duration was 2 years. These are the instruments which we have used in the study. The Appasamy keratometer, Zeiss IOLmaster 500, Biomedics EcoRoll Pro 2, and the drug used was tropicamide phenylephrine eye drop. The results via manual keratometry I have shown via 3 graphs. The pre and post values have been shown of K1, K2 and the axial length, and we have found that K1 and K2 measurements, it shows a significant difference before and after dilatation. However, the same could not be said for axial length. Via the optical method, we have found that the K1 and K2 value, again they are having a significant difference before and after dilatation, but axial length did not differ when we use these instruments. So I would like to conclude by saying that there is a statistically significant difference in the flat and steep keratometry values before and after dilatation via the manual and optical devices. However, axial length did not seem to be affected by pupillary dilatation via these methods. Also, I would like to comment that when we use these 3 instruments, there was no significant difference amongst in the values calculated via them, and I have shown them in the graph. The limitation of my study was firstly the age group. We excluded patients less than 14 and above 70 years. And secondly, another study has to be performed to evidently conclude if the biometric parameter should be taken before or after dilatation whenever we call a patient to the OPD for IOL calculation. Third, we have chosen only patients who have no other significant ocular disorder, which is not the case in real life scenario. These are my references. Thank you.
This just solves one problem in the clinic, which is should we check the IOL or the biometry when the patient is still dilated, or we should call him another time, or when he's undilated. But technically and in real life, I think a difference between a photopic and a scotopic pupil, the size would have been more relevant for the patient, whether the IOL power changes when a pupil is scotopic versus photopic. If that can be done, it would be more relevant for the
Okay.
patient.
Okay.
And it also depends on the degree of dilatation, isn't it?
Yes,
Now,
ma'am.
how many millimeters you are dilating, whether it's fully dilated or partially dilated.
We
because
had
that
included
will give
fully
you the-
dilated patients here, and any patient with less dilatation we had
Right.
excluded.
And as she rightly mentioned, the night vision, night vision, the pupil is not fully dilated, isn't it?
Yes,
It's only
ma'am.
bit dilated. And daytime, 12 o'clock, the pupil is very much constricted.
Yes,
Morning,
ma'am.
there's a diurnal variation of the size of the pupil.
And illumination in the clinic also.
Yeah. Thank you.
Thank you, ma'am.